Now, whenever this neuroanatomy content is there, which is a complicated and hugely extensive content. So, I just do not want to run through the detail of this particular neuroanatomy contents or the concepts. Rather, I will emphasize on the clinical thing that is related to it and this essential exam important parts which is important to us, because this is a super specialized content which is need to be understood at this undergraduate level, focusing on the clinicals. So, whenever we are going to talk about this particular parts of the neuroanatomy, whenever I am lecturing, I will be focusing on three contents whenever you are studying. So, first one is that the gross features, which is this particular organ have. That particular gross features will be emphasizing on which is clinically important or relevant, because the clinical cases that we are going to solve in our life. So, unless until we understand the clinical problem which is related to the gross features that is important to us will be dealt on. Second thing is that in this particular sections we call them as sectional anatomy, we call them as the cross-sectional view. We call them as cross-section neuroanatomy. That means if we cut it, how it is showing in this microscope, etc., etc. And again, this particular cross sections along with the gross things is linked up with this clinical understanding. So, round on, we will be going back to understanding this clinical anatomy related to this particular organ that we are going to cover. Now, today we have the content, we call them as content of the brainstem. So, brainstem is the middle portions of the brain which is lying between the brain, cerebrum and the spinal cord. Now, on this particular brainstem we have three components. Above one we call them as midbrain, then we have this pons and medulla. In short, we call them as VS as brainstem. It has three components. We call them as midbrain, then we have the pons, then we have the medulla, and within this particular content it has some kind of connections, we call them as peduncles. So, whenever we are going to study this particular pons, we are going to talk about the gross anatomy of this particular pons. In short, again we are going to talk about this particular cross-sectional anatomy in this particular region, which could be your exam question or used to be your exam questions, that the cross-section anatomy, but I will emphasize on this particular content which is going to be the future. We call them as clinical aspects of this particular pons, which is related to us to understanding the diseases related to it. Now, quickly go through this particular gross anatomy. As you see this particular brain part, we call them as the brainstem, this one we call them as midbrain, then this one which is a point of interest today we call them as pons, and then we have the medulla. So, this particular pons we will be focusing on have got some features, we call them as external features, that is a gross anatomy. When we are seeing that in a naked eye, how does it look like? So, it has two surfaces, one is this one which you are looking at, we call them as anterior surface, the other one which will be posterior surface. So, externally it has got two surfaces, external which is anterior and other one we call them as posterior, which is going to be covered in short. So, if you look at this particular features on this particular bone, this particular brainstem, we have this particular feature which is external feature on this anterior side. It has a midline groove over here, which you can see here, and these are the kind of yellow things which is projected out, which are nothing but the neurons or the collections of these neurons, which is known as the nerves, which is emerging from this region. We call them as the cranial nerves. So, this number of the cranial nerves which are exiting or coming out of this particular part of the brain and eventually going to different parts of our body to supply the muscle, skin, etc., etc., to give these functions is coming from this region. Now, on this region, on the external surface, it has a midline groove. We call this as basilar groove. This particular groove is occupied by a artery which is lying in here. We call them as basilar artery. Basilar artery is familiar with us because this particular artery is formed by the union of the vertebral artery joining there and running in this particular grooves, giving some kind of branches. We call them as basilar arterial branches, supplies this particular pons. And again, it splits into this basilar artery into two parts. We call them as cerebral artery, which is lying on the posterior side. We call them as posterior cerebral artery. So, this particular groove is occupied by a midline blood vessel, we call them as basilar artery, or the branches of basilar artery coming on. So this is a midline thing that we are seeing here. If you moving to the lateral side, we have this particular part of this particular brainstem on this pons region, we call them as peduncle. Now the peduncles are kind of like the nerve fibers which is going to the cerebellum. So these particular parts of this region which is communicating with the cerebellum, we call them as cerebellar peduncle. Now there are three such peduncles or kind of nerve tracts are there. We call them as superior, middle and inferior cerebellar peduncle. They are going to lodge into cerebellum and they are going to bring the fibers to the cerebellum or taking the fibers out of the cerebellum. That's why we call them as peduncles. We call them as superior, middle and inferior cerebellar peduncle. So this part you are seeing here is lateral most part of this particular external surface anteriorly of this pons, which is related over here. We call them as middle cerebellar peduncle. So middle cerebellar peduncle or middle peduncle in short, we can call them as middle peduncle like this. Now in between this basilar groove and this peduncle, we have a nerve exiting out here which is trigeminal nerve, fifth cranial nerve. So this trigeminal nerve is a mixed kind of nerve. It has a capability of picking up the sensation, which is have a sensory part which you are seeing here wider and thicker, and it is also providing motor supply to some of the muscles in the neck region. We call them as this motor division of the trigeminal nerve. Together it makes a common nerve which is a sensory and motor mix. We call them as a sensory and motor mix. We call them as mixed nerve. So this trigeminal nerve is exiting, seen in this particular region. Which part? In the upper part of this pons, which is close to the midbrain. So this is what the external surface is featured of. Now if you look at this, we talked about anterior surface which is having this groove, basilar groove lodged by an artery, we call them as basilar artery. Now lateral extreme we have this middle cerebellar peduncle or middle peduncle, and in between them we have this trigeminal nerve which is seen to be exiting out of it. So this is about the external feature which is present in the anterior or ventral surface. Similar to that, if you move to the posterior side, which is related to the external feature of the posterior side, which is this. So posterior to that, we have this region occupied by the cerebellum, which is removed out here. So cerebellum is removed from here. Now it opens this particular midline depressions over here. This is a cavity of the fourth ventricle that we are seeing here, which is covered by this cerebellum. Once you have this cerebellum need to be removed by cutting this cerebellar peduncles. As I mentioned, there are three such peduncles or tracts are there. We call them as cerebellar peduncle. There are three of them, 1, 2 and 3. We name it superior, middle and inferior cerebellar peduncle. They are more visible and pronounced from the posterior side of the brainstem. So if you go back to the POC side, cut this particular cerebellum from these peduncles. Now this particular cerebellum can be removed out. Then you can see this particular upper part. This is this upper part cavity of the fourth ventricle formed by the pons. Lower part is formed by the lower segment of the brainstem. We call them as medulla oblongata. So this what exposed is over here is the cavity of the fourth ventricle. The cavity of the fourth ventricle and the features we have covered. Again we will cover that features in practical classes. But again we see that it's a cavity in the midline. We have a groove. We call them as median sulcus. Then if you go back laterally, we have this sulcus limitans, another groove on the lateral margins. Then we have this area, we call them as vestibular area. So this region between this median sulcus and this sulcus limitans, we have a bulge. We call this bulge as median eminence. On this median eminence, we have a central bulge, we call them as facial colliculi, which is the nucleus of the facial nerve is present in here. If you cut section of this region, we will see this particular nucleus and these other nerves as well. So we go to the cross sections later on. So this is how this posterior surface of this region looks like, or the posterior surface or posterior external feature of the pons, which is having a cavity of the fourth ventricle, and fourth ventricle cavity have got features which is covered in the floor of the fourth ventricle beforehand lecture. I am not going to it. And then on the lateral extreme we have these peduncles visible, superior, middle, and inferior cerebellar peduncle. That means these are fibers that is going to the cerebellum or coming out of the cerebellum, going to supply or communicate with the brain, cerebellum and the spinal cord together. So this is about the gross external features of it. Now moving to the important part which I emphasize on this particular specimen over here, we call them as pontomedullary junctions. In short, we call them as PMJ. So pontomedullary junctions is a union site where this particular pons ends and joins with the lower brainstem segment. We call them as medulla oblongata, and this region which is demarcating roughly that region, we call them as PMJ or pontomedullary junctions. Now you see that from these pontomedullary junctions, in numbers of the yellow strings are coming out. What are these yellow strings? These are cranial nerves which are coming out. So from medial to lateral, we have a number of the nerves coming out. So most medial is a nerve which is 6th cranial nerve. Then we have the 7th cranial nerve. Then we have the 8th cranial nerve. So we have 3 nerves emerging from the pontomedullary junction. So this pontomedullary junction is a point of clinical interest. We have a clinical problem and we have to explain the clinical problem based on this pontomedullary junctions issue. So we have to know what do you mean by the PMJ or pontomedullary junctions, which is nothing but the union point between the pons and medulla. And what's the speciality about this PMJ? This particular pontomedullary junctions ventrally and posteriorly, we have a union over here which is related. Posteriorly it has the cerebellum, anteriorly it is these nerves emerging off. Medial to lateral, 6th cranial nerve, 7th cranial nerve and the 8th cranial nerve coming out of it. So we have this abducent 6th cranial nerve, then we have this facial nerve, 7th cranial nerve and this 8th one which is present in here. The 8th one have got 2 components. We call them as cochlear component and we call them as vestibular component. So 8th cranial nerve, we call them as together auditory nerve and vestibulocochlear or vestibulocochlear component, which is vestibular and cochlear. So cochlear component is dealing with the hearing and vestibular component is dealing with the balance, which is related to the middle ear cavity. So this 8th cranial nerve, we call them as this 8th cranial nerve together as the auditory nerve. It has got 2 nerves component. What is it is doing? It is helping us to listen things. There's number 1, which component? The component which is helping us to listen is cochlear component. Other one is keeping the balance so that we can stand still, helping with this person move in a straight line manner. We call them as vestibular component. So it has 2 different nerves emerging from this region. So this PMJ is important or super important for us. So this is about the gross feature that covers this particular region. Now we are going to talk about the next one. We call them as this particular internal features. This is in short about the gross features of this pons. So this single chart basically represents the gross features of the pons. If you remember, this chart is more than enough for our exam, for our understanding at the undergraduate level and solving the clinical problem as well. So let's move to this particular gross features to this internal feature. We call this as cross section picture. That means you get the pons, you cut this pons and stain it, see under microscopes how these things looks like. Now, whenever you are seeing this particular neuroanatomical content, you are going to see 2 basic components in this brain or neural regions. One is we call them as ganglion and other is we call them as fibers. That means these neurons have got 2 parts. One is the cell bodies. The collections of the cell bodies, we call them as ganglions or cell body collections. In short, we call them as the nucleus. In the central nervous system, it is present, we call them as nucleus. In outside, we call them as ganglions. So collections of the cell bodies which is present, either nucleus or ganglions are present. The second thing, these neurons have got projections. We call them as fibers. That particular fibers are coming from the axons and the dendrons. So these 2 components of these neuronal elements we are going to see along with the supporting element. We call them as glial cells. These are the architecture of the neuronal cells. So 2 components are there whenever you are addressing this. One is the nucleus or ganglion, depending on if it is inside the central nervous system or outside. This is the collections of the cell bodies of the neurons. They are together making these things together. Other things is fibers. which is formed by the actions and the dendrons. They are making the tracks, different kind of tracks they are taking. We call them, referred as peduncles. Peduncles are nothing but the tracks which are formed by the nerve fibers, first degree, second degree, third degree fibers which are coming and making this particular roadways. We call them as tracks. So whenever in the pons we are going to see the cross section things, we are going to see two things. One is the collections of the cell bodies in forms of nucleus and tracks which is known as fibers or fibrous tracks. So this particular pons can be cut into two regions, upper sections and lower sections of the pons. So this particular pons, if you cut here, it looks like this. So this is the cavity of the fourth ventricle side and this is the ventral side that we are looking here. This is the ventral most portions, this is the posterior most portion. Posterior one, that means it is the dorsal side, this is the ventral side. The same nomenclature exists in here. So whenever you are seeing this, we divide this particular pons internal structure into two parts. We call them as ventral part and dorsal part. Ventral part we call them as basilar part, we give a special name to it. If you cannot remember this which is basilar and which is tegmental, just like remember this particular ventral and dorsal, this is good enough. So this ventral part is this one and this one is dorsal part. So this ventral part architecture is little different with this dorsal part of the architecture. So we are going to address this particular difference of this ventral part and the dorsal part architecture in short, which we can memorize, which we can produce. What is expected of you here is that this internal structures of the pons or microstructures, whatever the nucleus or the tracks are there, you should be able to produce with the schematic pictures if it is given on your examinations. How the questions can be asked? The questions may be given to you, draw and label a cross-sectional pictures of the pons and they will be given in the pons. You can draw any sections, upper sections or lower sections. If they specify the upper sections of the pons, that you have to draw a picture, cross-sectional picture of the upper part of the pons, lower part of the pons, you have to draw a lower section picture of the pons. This is what is old questions used to come. Nowadays, it is going to replace by the new anatomical questions which are clinical relevant, more clinical relevant questions are occurring. So this drawing a cross-sectional picture is difficult anyways, that you have to remember and memorize. So anyways, whenever this gross pictures you are seeing here, this part we call them as the dorsal part, this one is called them as ventral part. So each of this dorsal part and the ventral part is occupied two things, again same thing, nucleus, fibers. Nucleus and the fibers, they are present. So whenever you are going to see, we are going to talk about that. So this region we call them as the ventral part. This one is a dorsal part. Ventral part we call them as basilar part. Dorsal one we call them as tegmental part. So these are the two things. Now take this part as this region. We call them as ventral part of the pons. This has got features. You see the dots over here. These dots are nucleus cell bodies. So this was nucleus which is present in here. We call them as pontine nucleus. Easy to remember. And the fibers which is present in here, we call them as pontine nerve fibers. It may be corticospinal, it may be pontofibers, it may be portocerebellofibers. Different kinds of pontine fibers are there in this segment. So two components are there in this basal parts. So basal part have got two elements, nucleus pontis or pontine nucleus and nerve fibers here. If you cannot remember this particular nerve fiber names, just don't go for it. Just mention it, nerve fibers and pontine nucleus. You will still get the full credit of it. If you can remember better, you will be getting a better decorated answer, or better answers will be carried through better marks. If you cannot, just answer this nucleus and the fibers, they are present. We call them as pontine fibers and pontine nucleus. That's all. So this basal part have got these two architecture. This part, dorsal part, which is little bit complex. That's what we have to bring it or make it little bit sequential. So this dorsal part, this one basal part, red part we have done. This part we call them as, in purple we are seeing here, we call them as dorsal part, also known as tegmental part. What the tegmental part has? It has fibers, it has nucleus. What nucleus it has? It has a cranial nerve nucleus which is exiting through their pontocerebellar junctions, PMJ. You remember the nerve 6, 7, 8, we have seen these nerves which are exiting out. The cell bodies of those nerves are present in here. So these cell bodies nuclei of the 6th cranial nerve, 7th cranial nerve and 8th cranial nerve are there. Eighth cranial nerve, we have two components, vestibular and cochlear. Each of them, these cochlears and the vestibular nucleus, they are many. That means 2 or 4 maybe vestibular and cochlear nuclei are there. And along with that, we have the 7th cranial nerve nuclei, 8th and 6th cranial nerve nuclei are there. Along with that, we have some additional sensory nucleus are there. We call them as salivatory nucleus, superior and inferior salivatory nucleus. Superior one is visible in here, inferior one is also visible in here. We call them as nucleus which is going to supply the lacrimal nerves. We call them as lacrimatory nuclei. And again, nuclear tractus solitaris or sensory nucleus for the 5th cranial nerve, they are present. Now, how do these things look like in a cross-section picture? This is how it looks like in a cross-section picture. It's complex, but again, you have to prepare this for your examination. This part we have covered, the pontal nucleus and the fiber system. This side, we are going to see the complex thing. Now, think over here, this is the cranial nerve, which is 6th cranial nerve, and this is 7th cranial nerve. Now, this exit of these two nerves is important. You see that the 7th cranial nerve nucleus is there, and this is the 7th cranial nerve is coming out, forming over here fibers and getting out of here. So, this is the 7th cranial nerve which is facial nerve, and this is the 6th cranial nerve which is coming on here. So, 6th cranial nerve abducens which is exiting straight over here, running posterior side, going to the anterior side and exiting. How this particular motor nucleus of the facial nerve is coming? This is winging around or making a round trip around this nucleus of the 6th cranial nerve, making a hook and then again coming out. So, this hooking or moving of this is because of the neuronal motor migration. So, we call them as neurobiotaxis. Initially, this particular nucleus was here. It moved to reach to this particular nucleus. Close to this nucleus, it want to come. What nucleus it want to come? It want to come close to this trigeminal nerve nucleus. Where is the trigeminal nerve nucleus? This is where it is lying. This is the sensory part of the trigeminal nucleus. This 7th one wants to come close to this particular nerve, which is the 5th nerve. Why? Because the actions of the 7th nerve and actions of this 5th nerve is close by. So, they want to go side by side so that they can corroborate and understand each other well. So, this movement of the neurons like this, moving like this, winging around, we call them as neurobiotaxis. Neurobiotaxy, that means it is moving. So, neurons biologically moving, we call them as neurobiotaxy or taxis. So, this movement of the neurons like this phenomenon we call them as neurobiotaxis. But again, this is a research topic. So, I do not see any clinical significance in knowing about this, but this things is happening in here, which is a kind of interesting phenomenon. So, again, anyway, 6th cranial nerve which is exiting here, 7th cranial nerve which is exiting, making a cell bodies here, nerves is exiting like this. We have the other nuclei, we call them as 8th cranial nerve nuclei. 8th cranial nerve nuclei, we have two components. We call them as cochlear component, vestibular component. The cochlear nuclei are over here. So, these are two cochlear nuclei, we call them as dorsal and the ventral cochlear nuclei. They are around the inferior cerebellar peduncle. So, this is present around these regions. Now, this is what you are saying over here, you call them as cochlear nuclei. Then we are left with the vestibular nuclei. So, these are vestibular nuclei. Usually, they are 4, anterior, posterior, superior, inferior, but 2 of them are visible in here. So, we call them as vestibular nuclei, 2 of them are visible. So, these vestibular nuclei and cochlear nuclei together makes this nerve which we call them as 8th cranial nerve. So, 6th cranial nerve nuclei, 7th cranial nerve nuclei, 8th cranial nerve nuclei and the 5th cranial nerve nuclei which is sensory part which is present in here, we call them as the spinal tract and spinal nucleus of the trigeminal nerve, they are present. So, these are the nuclear collections, they are present, they are important, you have to remember these names. Now, other than this nucleus, there are several. This one, we see that this purple one, we call them as salivatory nucleus. The salivatory nucleus along with this particular other nuclei go with the facial nerve and forms along with it, forms a chorda tympani. It forms this particular nerve over here, we call them as superior salivatory nucleus with this lacrimal nucleus. They join together, join this particular facial nerve and come out as nerve, we call them as chorda tympani, which is going to supply this particular like as lacrimal gland, salivary gland, etc., etc. So, this is how this particular nerves and nucleus are present. What else we have? we have this particular tracts. We call this as a tracts which is present in here. This green one which is a present of a tract, we call them as lemniscus. This lemniscus we call them as medial lemniscus. Next one to it, we have lemniscus which is a tract, we call them spinal lemniscus. These are the two things which is present. Along with this one, we call them as the medial longitudinal bundle. So these three fibers or names of these tracts that you have to keep in mind. So moving back to this particular content over here that we have to produce. So this tegmentum or posterior part have got nucleus, gray matter, which is the nucleus of the 5th, 6th, 7th and the 5th that is present, 5th, 6th, 7th and 8th which is present in here. Along with that, we have this adjective nuclei or adjacent nuclei, we call them a salivatory lacrimal nucleus that are present. So we stop at this particular nucleus points and how they are present, we have to remember these particular pictures, how they are coming. Now other than this, we have the tracts. This tracts means white fibers. Out of these particular white fibers, we have to remember the spinal and medial lemniscus, which is easy to remember, and trapezoid body and this particular nucleus which is present in here, we call them as this one. We remember this medial longitudinal bundle because this is important clinically, this green one on top. So medial longitudinal bundle, number 2 and number 3 is the rubrospinal and tectospinal. They are important, but this one medial longitudinal bundle is important for us. We will talk about later on why this number 1 is important clinically. These two we call them as tectospinal ligament. It's going to the tectum part of this, going to the spinal cord, rubrospinal, going to the red nucleus of the midbrain to the spinal cord. That's why you name that. But you just like to know these particular components over here. So we cannot remember all of these names, but we have to remember this nucleus and few fibers. We recommend here to remember the spinal lemniscus and medial lemniscus, these two, and medial longitudinal fibers over here, and this particular big collections over here, we call them as inferior cerebellar peduncle. So these contents of this cross section picture of this region that we have to remember. Second thing about here is that this is the section which is taken from the pons at the lower level. If you take a sections on the pons at the upper level, it looks like this. So it is upper pons, that means it's close to the midbrain. You take the cross section picture and it looks like this. This is the cavity of the fourth ventricle it is holding, and this is superior cerebellar peduncle. We see that inferior cerebellar peduncle in the lower section. So this section brings out two sections, superior cerebellar peduncle and middle cerebellar peduncle. The inferior one is way down, that's why it is not coming in here. So this cavity which you are seeing here, fourth ventricular cavity which you are seeing here. The only nucleus that is present in the upper level is this one. This is the two nucleus that is present on the trigeminal nerve, which is sensory nuclei and the motor nuclei. This spinal cord, this trigeminal nerve have got 4 nuclei. So 4 of these, 2 of this present in here, we call them as motor nuclei and the sensory nuclei, they are present. So this one is the motor one which is present in the midline, M by M, and laterally one which is present in here with the sensory one. They are coming together and making this particular united together as this particular nerve which is the trigeminal nerve exiting here. So this is the only nuclei that is present in the upper level or cranial nerve nuclei. Other than this, we have this bundles, we call them as lemniscus. So this lemniscus which is seeing here, medial lemniscus, then we have the trigeminal lemniscus. These are the tracts which call them as spinal lemniscus, and the lateral one you call them as lateral lemniscus. So this particular gray matter of this particular lower sections of the pons have got gray matter nucleus, which is the nucleus of the trigeminal, sensory and motor. The white matter is the lemniscus, and along with that the same thing we call them as number 1, you call them as medial longitudinal bundle. So these two you have to remember. So these 4 and this one at least we have to remember, and on this posterior side is the same, pontine nucleus and the pontine fibers. So these pontine fibers are of types, we call them as cortionuclear, corticospinal, etc., etc. But if you do not remember all of them, we just remember the pontine nuclei and pontine fibers. In case of this particular dorsal part, you have to remember this complicated thing. So this picture and this picture you have to remember, draw it in a schematic diagrams with this pointing on it, emphasizing on the nucleus which is present, which you call them as gray matter nuclei which are present, and the white fibers which I mentioned about, you have to mention about a couple of them. So this is about the gross features of this region. So lower part gross features that you have to remember this, basilar part and the dorsal part. Basilar part same, pontine nuclei, pontine fibers. Dorsal part is easy, we have the nucleus of the trigeminal nerve, sensory and motor. Fibers, we call them as lemnisci, and the medial longitudinal bundles which is present to it. So this is in short, or this thing that you have to remember about three sections over here, three segments about here, gross features, sections in the upper part of the pons, lower part of the pons with the pictures in it. Coming to the clinical part, which is important to us. The pons is supplied by the basilar artery, runs in the basilar group, which is giving the branch, we call them as basilar branches of pontine arteries or pontine branches. Along with that, we have this inferior cerebellar artery that also contributes to, along with the superior cerebellar artery, that also gives brief supply to this particular pons. But this pontine artery which are coming from this basilar artery is a prime source of the blood supply. Now, if you have any kind of accident to this blood supply to it, that means cerebrovascular accident, we call them a CVA in short. That is, if these arteries are ruptured, if we have this stoppage of the blood flow to it, we get a very clinical problems. We call them as pontine hemorrhage. That means if the artery bleeds, that leads to hemorrhage to the pons, we call them as pontine hemorrhage, always threatening if you have the bleeding affecting in the pontine branches of these arteries and leads to hemorrhage in the pons. So we have a pontine hemorrhage that is very problematic over here. Second clinical problem that we call here, we call them as Miller-Goubler syndrome. So what is happening over here, Miller-Goubler here, we have this particular anterior segment or ventral segment of the pons receiving less blood supply or lack of blood supply. So we have a hemorrhage affecting in this shaded region over here. So if you have a hemorrhage affecting in this region, it catches two nerves which is exiting in this region. So this particular region, you see the cross section is lying in the lower part of the pons. So lower pontile region, if you have a hemorrhage, it affects these two cranial nerves, which is 6th cranial nerve and 7th cranial nerve. 6th cranial nerve is dealing with the ocular movement. So if the 6th cranial nerve is not working, we have a problem with the movement of the eye. We call them as squint. So we call this kind of squint is convergent squint. So, or again, if you cannot remember this convergent or divergent squint, which you need not have to remember, you see that this Miller-Goubler clinical problem with this affecting the abducent nerve, 6th cranial nerve, leading to squint or ocular movement error, that also serves this purpose of expressing or what is happening here. Second thing here, it affecting the 7th cranial nerve. If you have 7th cranial nerve is affected by this hemorrhage, we have the problem which is coming to it. That means the 7th cranial nerve is a sensory and a motor. That means we are affected with the 7th cranial nerve which is taking up the taste sensation. That means loss of taste sensations will be there, and along with the facial nerve supply the facial muscle of expressions. So loss of facial muscle expression or facial palsy. We call them as palsy as is not movement of the motor actions, or paralysis, which is in short we call them as palsy. So paralysis of facial muscle of the same side, and along with the taste problem because of this particular facial nerve carries the taste fibers to the tongue. Along with that, we have the damage to this particular abducent muscle. That means extraocular movement of the eyeball is hampered or damaged. That is what is happening over here. Then it is affecting this particular pontine nuclei and pontine fibers. That is affecting the motor actions. We call them as hemiplegia. So lack of actions of this particular half of the body of the affected side or opposite side will be affected. We call them as contralateral hemiplegia. So this is what it is happening over here in case of the Miller-Goubler syndrome. That's what you have to know about. This is the relationship of this particular clinical problem with the blood supply to this particular pontine regions. Second one, which is more important, that I would emphasize more on preparing out here, we call them as PMJ tumor or pontocerebellar angle tumor. So this particular tumor which is affecting the PMJ or pontomedullary junction. Now pontomedullary junctions is exiting number of nerves, 6th cranial nerve, 7th cranial nerve, 8th cranial nerve, they are coming. So each of these nerve may be affected by a tumor affecting in this region. If you have a tumor encroaching in this region, we call them as pontomedullary junction tumor or PMJ tumor. So if you have these nerves affected, the same thing will be there. Sixth nerve is not working, we have extraocular muscle problem. Seventh nerve is not working, we have two issues. One is the palsy or paralysis of the muscle that is supplied by this nerve. Second thing, it is leading to taste sensation error. Third thing which is happening in here is the eighth nerve is affected in here. Eighth nerve affected, that means we have two problems. Auditory problem because of the cochlear component. Vestibular problem will be leading to the balance problem because of the vestibular problem. So this particular person who has this particular pontocerebellar angle tumor will have the clinical problems affecting damage to the facial nerve, damage to the vestibular cochlear nerve, damage to this particular extraocular muscle, and this particular cerebellum also will be damaged, leading to this particular ataxia or movement error. How this particular region or PMJ or pontomedullary junctions region can be affected out here? We have this particular cranial nerve which is exiting in here. We have seen this eighth cranial nerve. So this eighth cranial nerve, the covering of the eighth cranial nerve may be enlarged because of some diseases or enlargements of here. We call them as schwannoma or schwannoma affecting this particular tumor side of the PMJ. So if the tumor is running over here, small one, it will be affecting this particular vestibulocochlear nerve. If it is growing big, it will be catching up this particular nerve which is next to it, the seventh one. If it becomes even much bigger, it will be catching up the sixth cranial nerve. And if it is going on encroaching on the back side, it will be affecting or catching up this particular cerebellum which is present in this region on the posterior side. So how these particular things are coming with this pontomedullary junction tumor is important to us. So this particular pontomedullary junction tumor is more common or more frequently encountered. The first clinical problem will be arising out of here is affecting this particular vestibulocochlear nerve. That means if it is an early problem, that will be the patient will be complaining of the hear problem or hearing problem along with this particular balance problem. So the patients may be having a hearing problem along with this some kind of abnormal sounds they may be hearing. We call them as tinnitus, and along with that they may be having a difficulty in walking in the straight line or maybe falling frequently. That could happen. If it is going further bigger, that thing is added up to this particular involvement to this facial nerve. If the facial nerve is involved, that means the facial muscle paralysis and the taste sensation will be added to it. Then if we have the sixth cranial nerve, we have the loss of extraocular muscle movement, we have a squint issues. Likewise, it is going. If it is a super huge going on and bigger, even in here, encroaching to this particular cerebellum, we have the ataxia. We have the problem in walking straight line, we have the movement of the eyeballs which is affected out here. So this particular PMJ or pontomedullary junction is maybe coming as a short note in examinations with the clinical relevance to it. That means if you have the PMJ given as a short note, which is easy to decode, we have to mention and arrest this gross anatomy in this particular picture, that is what is PMJ, what is the clinical thing that is, or what is the gross thing that is present in the PMJ. Second is clinical problem, PMJ tumor. In this PMJ tumor, we call them as pontomedullary junction or pontocerebellar angle syndrome or pontomedullary action tumor. So affecting this particular cranial nerves and bringing these clinical problems. So in short, we have to remember few things about this particular Pons. The gross things about features of the gross features of the Pons, external features. Then we have to remember the cross-sectional pictures, lower sections of the Pons, basilar part and dorsal part, gray matter, white matter. Upper sections also have the same thing, basilar part and dorsal part, gray matter, white matter, what it is in the gross. Along with that, the clinical problem emphasizing on the PMJ or PMJ tumor, which is pontocerebellar angle syndrome, and then we have to talk about the pontine hemorrhage, always threatening, and Miller-Guebler, which is affecting this particular arterial supply blockage of these regions, affecting the basilar artery or inferior cerebellar artery, which is supplying to it, leading to this particular clinical problem, catching up this particular facial nerve and the sixth cranial nerve, leading to this particular ocular muscle movement error and facial nerve error, which is leading to the palsy. That means muscle paralysis with the taste sensation error. So these two entities are the clinical problems that you have to understand with the gross features and the cross-sectional pictures. So in examination, in the Pons, If it is coming as exam questions, these are the regions that you need to understand. Okay.